Inside a single cell, a meticulously coordinated sequence of metabolism can abruptly stop. A single genetic error causes a key enzyme to fracture and halt its catalytic function. This single missing piece changes how the body processes and utilizes systemic amino acids, triggering a cascade of biochemical failures. The physical evidence of this internal damage eventually surfaces in the circulatory system. Plasma proteins circulating in the blood serve as markers for these microscopic disruptions. Measuring these proteins provides a real-time diagnostic map. Their specific concentrations reflect the state of both inherited genetic errors and acquired hepatic failures. Identifying the specific link between a pathway defect and its resulting blood profile allows for a systematic approach to clinical pattern recognition. Inborn errors of metabolism follow a strict rule. An enzyme deficiency creates a blockade in a biochemical pathway. Consequently, the body is starved of downstream products. More dangerously, unable to move forward, upstream precursors begin a toxic accumulation in tissues and blood. Knowing exactly where this block occurs in the timeline of metabolism allows a clinician to predict the specific toxic buildup and the resulting disease phenotype. Phenylketonuria, or PKU, provides a clear example of a first-step pathway block. This diagram isolates the specific failure. The enzyme phenylalanine hydroxylase, marked by the red cross, fails to perform its catalytic role, preventing the normal conversion of phenylalanine into tyrosine. With the primary exit route sealed, phenylalanine accumulates in the blood alongside secondary metabolites like phenylacetate. This specific buildup generates the clinical triad of untreated PKU: severe intellectual disability, hypopigmentation of skin and hair, and a characteristic musty odor. Because the normal synthesis pathway is severed, tyrosine becomes an essential amino acid for these patients. It must be explicitly supplied in their diet. Moving further down the tyrosine breakdown pathway, this schematic shows a distinct block at the enzyme homocystinuria 1,2-dioxygenase, resulting in Alkaptonuria. This specific enzyme failure causes an accumulation of homocystinuria acid. Upon exposure to oxygen, such as when urine stands for a period of time, this acid oxidizes into a dark-colored compound. This photograph captures a complication of Alkaptonuria. The bluish-black discoloration on the hands is ochronosis, caused by the accumulation of melanin-like polymers in connective tissues. While PKU and Alkaptonuria originate in the breakdown of the same amino acid family, the specific location of the enzyme block produces distinct systemic diseases. We apply this same logic to the breakdown of branched-chain amino acids, leucine, isoleucine, and valine. This chart highlights the cause of maple syrup urine disease. A deficiency in the branched-chain alpha-keto acid dehydrogenase complex prevents the breakdown of all three branched-chain keto acids into simple sugars. The rapid buildup of these branched-chain amino acids in the blood produces an aggressive phenotype, characterized by sweet-smelling urine, severe ketoacidosis, and neurotoxicity. Pivoting to methionine metabolism introduces the mechanics of homocystinuria. This biochemical schematic isolates the transsulfuration pathway. The specific defect lies with cystathionine beta synthase, disrupting the conversion of homocysteine into cystathionine. The resulting accumulation of homocysteine circulating in the plasma damages connective tissues and the vascular system, manifesting clinically as marfanoid habitus, optic lens subluxation, and an increased risk of thromboembolism. By contrast, albinism isolates a defect exclusively to melanin synthesis. A localized tyrosinase deficiency halts the conversion of tyrosine into DOPA, resulting in a pigmentation failure without systemic metabolic buildup. Identifying the specific toxic byproduct, whether a syrup odor, spontaneous blood clots, or pigment loss, allows you to trace the pathology back to its genetic root cause. Moving to the blood vessel, the liver synthesizes 90% of plasma proteins. Albumin generates the oncotic pressure required to hold water inside the vascular compartment. Without sufficient albumin, fluid leaks out of the vessels into the extracellular space, resulting in edema and ascites. Globulins circulate alongside albumin, acting as a protective shield and transport mechanism for the immune system. Acute phase reactants serve as the measurable markers used to identify systemic inflammation. Severe liver disease drops the vitamin K-dependent clotting factors 2, 7, 9, and 10. Without these synthetic outputs, the coagulation cascade is compromised. Analyzing plasma proteins provides a quantifiable measurement of a patient's biophysical stability and their risk for hemorrhage or fluid collapse. As we have seen, a singular microscopic genetic defect in an enzyme can trigger a cascading metabolic disaster throughout the entire body. Monitoring plasma protein levels allows you to quantify the physical extent of systemic damage. Mastering these connections allows you to trace a patient's physical presentation directly to the biochemical error. By carefully reviewing the universal pathway block and systematically mapping the resulting clinical phenotypes across all these major metabolic disorders, you can leverage this master diagnostic matrix to cross-reference specific genetic defects with their symptoms, assess the biophysical stability of the plasma to identify fluid collapse, and drastically reduce the time needed for a successful differential diagnosis.